Intestinal obstruction. Now, moving on to the intestinal obstruction. Obstruction can be at small bowel level and at the large bowel level. So, what can be the causes behind the obstruction? First and foremost cause is the malignancy, in which peritoneal carcinomatosis is most common malignancy responsible for the small bowel obstruction. And further causes for obstructions are Crohn's disease, hernia, or any pelvic surgeries which lead to the adhesions in the lumen of the small and large bowel. So, pelvic surgeries constitute mostly for the adhesions, and secondly are the lower abdominal surgeries, and at third number upper abdominal surgeries which lead to adhesive intestinal obstructions. Now, moving on to the symptoms or the clinical features part, what we see in a patient of intestinal obstruction. First of all, patient comes with a complaint of sudden severe colicky pain and with a history of bilious vomiting. Constipation is there for more than 3 to 4 days due to obstruction. Vomiting can be there, and dyselectremia or a toxic look could be present due to disturbed electrolytes. Most common seen in the proximal obstruction, and there could be distension of abdomen which is mostly present in the distal obstruction, and also sometimes due to obstruction or due to constipation there is enlargement of food particles into the intestine which leads to mass-like entity that puts pressure over the IVC, which further lead to the decreased venous return to the heart and also leads to the dehydration, or we can say as it lead to hypotension, dehydration, and due to decreased venous return cardiac output decrease, so in return tachycardia is present, and also there are decreased bowel sounds or sluggish bowel sounds are noticed. All these are the symptoms of intestinal obstruction. Now, how can we diagnose a patient with intestinal obstruction? First and foremost investigation we do in these kind of patient is X-ray. X-ray is taken in supine or erect position. In erect position, what we see in the X-ray, air fluid levels are seen. This is the most characteristic feature of the intestinal obstruction. If it is seen, we directly jump onto the diagnosis that it is intestinal obstruction, and we can confirm further it by the CT abdomen. And in spine and in supine X-ray, we will see obstruction site. Now, in CT abdomen, this is done for confirmation of the diagnosis. What we will see in the CT, we can see obstruction site, at which site obstruction is present or what type of obstruction is there, whether it is strangulation type or complete or extrinsic obstruction is there. Another blood tests are performed, complete blood tests are performed. EBG is also done to rule out acidosis or any alkalosis condition. Fever could be present. Now, what will look in lower, what we will look in X-ray of lower intestinal obstruction. There will be valvulae conniventis seen, which is characteristic of the jejunum obstruction, and in ileum obstruction this is featureless and symptomless. Also, bowel loops are placed peripherally or wider in the lower gut, so there would be presence of hostra could be seen in the X-ray. Also, regarding the gases, in small bowel obstruction, gases are seen in the rectum, and in large bowel obstruction, no gases are seen in the rectum. Further, moving on to the management part, immediately patient will be admitted to the hospital and all the blood routines checkup will be done. IV fluids, preferably ringer lactate solution, is given. Foley's catheter is introduced, which is best indicator for the tissue perfusion, so that we can look for the urine output quantity. And Ryle tube insertion is there for proximal decompression. And patient is ultimate treatment for obstruction is surgical. After admitting the patient or checking or performing all the tests, ultimately confirming the diagnosis that patient is having the obstruction, finally we will do the surgery. In this, we will do the resection of the part where the obstruction is present, and anastomosis is done after the resection between the two normal parts of the gut. And if there is hernia is present, then reduction is done for the hernia. And if Crohn's disease is present, then also we will do the resection and anastomosis. And in adhesions cases, we do adhesiolysis in adhesions. These are the methods to manage the intestinal obstruction. Thank you.